So I'm going to start today just to give you some context for the work that we're doing with Masheed, tell you a little bit about the Camden Coalition of Healthcare Providers, talk to you about the way that we approach data and use data at the Camden Coalition, because it really informed the way that we designed this research project with Masheed, and then talk to you about the research that we are doing with Masheed around asthma, pediatric patients who utilize the hospitals in Camden for asthma-related complications. It's a mixed methods study, and I've been mostly involved in the quantitative aspects of those studies, so working to use our claims database to identify patients who are using the hospitals for asthma-related conditions, and then designing a cluster analysis in collaboration with a couple folks that are here today. Thank you very much. And I'll be talking more about that. And then the other piece of this research was focus groups that were involved identifying patients that really fit into the clusters that we identified in the claims database. And Masheed will talk a little bit about that. I'll share some of the findings and some of the important implications from this work in terms of designing interventions to reduce hospitalizations and ED utilization for asthma among pediatric patients. So just to give you some background, again, I'm from Camden. How many of you are familiar with the Camden Coalition of Healthcare Providers? Okay, and the city of Camden, we have been in Camden for a bit over a decade now. And just to give you a little bit of context about the city of Camden, Jason informed me that it's comparable to Flint, Michigan, and the Camden is always, when people talk about Flint, they always reference Camden as a comparable city in terms of its demographics, as well as its economic profile and social profile. It's a city that's been struggling for a long time. One of these cities that we hear about so often that, in the 60s and 70s succumbed to a lot of demographic changes, a lot of de-investment, poverty rising over the decades, unemployment. We have a very high poverty rate, very high unemployment rate. All those dire statistics, right, they can associate with post-industrial cities that have gone through troubled times related to all sorts of institutional and structural inequalities and discrimination, et cetera. Excuse me, I also have a little allergy issue going on, so hopefully my voice will last through this. But the Camden as a city is small, less than 80,000 people, with 3 hospital systems that operate in the city. It's a city that is undergoing pretty important changes right now in terms of development. There's a lot of big name corporations coming into the city, setting up shop down near the river. We're right across the city from Philadelphia. So again, we've been working, Camden Coalition, which is a nonprofit membership organization based in Camden, has been working for over a decade to really bring providers throughout the city together to really improve the quality and capacity of healthcare in the city of Camden. We were founded by a family physician named Jeff Brenner, who was extremely dedicated to serving the Medicaid population in Camden, really working with them, but realizing pretty quickly after he moved from Seattle that Camden's a very challenging place to work. He set up shop right at a time when there's a lot of changes happening in the healthcare system, and he was really seeing people cycling through his office that were really not just medically sick, but were really exhibiting major signs of trauma in their lives and having a lot of behavioral and social complexity, housing instability, for example, addiction struggles. So he brought together providers throughout the city to form a breakfast club, really, to talk about what providers are witnessing in terms of the challenges and barriers to accessing quality care and reducing costs. And among the people seated at the table were representatives from the 3 competing hospital systems in Camden. Right? So the situation was seen to be so dire that even the institutions that are seen as competitors were willing to sit at the table with other providers and try to figure it out. So since that time, we have become, I was just telling Masheed a minute ago that our model is very much aligned with the work that Masheed is doing and what she's trying to build in terms of we, from the very beginning, have prioritized relationships, engagement, partnerships, and really bringing people to the table across different silos, right? Really breaking down silos. We are a convener. We work, we'd like to refer to ourselves sometimes as a neutral body in the midst of the community, government, social services, and healthcare in Camden at the state level and increasingly nationally as we've become now a national center for complex health and social needs. And I should also mention that the coalition, the organization itself is kind of complicated. I was trying to explain it in a very short period of time to Neil this morning, and he's like, "What? I don't really understand it." It's like, what is this organization that you're talking about? And that are you a provider? Are you an ACRU? Are you an insurance company? What are you? We are an organization that has grown from that really small core of folks sitting around a table trying to figure out how to transform the healthcare system. We started out as, we developed a multidisciplinary team of providers to work with the most complex patients in Camden early on. These are folks that have become known super utilizers of the healthcare system. We started out as I said, a multidisciplinary care team, and have grown into an organization of over 100 staff that work at the front lines, right, and in all different areas with a primary goal of transforming healthcare so it is more responsive to the needs of not only the complex patients, but all patients, right? But we started, our bread and butter work has always been with those patients who sort of fall through the cracks of not just the healthcare systems, but all of the systems that they touch, right? So we work for direct healthcare providers. We work with practices to redesign clinical services. We work, we have a legal policy and advocacy team that works with the state to change healthcare policy. We have a cross-site learning team that works across the country to work with teams in different healthcare systems to respond better to the needs of individuals who have very complex medical, social, and behavioral health needs. And we have a big data and research team that provides not only data analytics for our teams that really help the operations of our care teams and rapid feedback loops so that our care teams know how they're doing in terms of engaging patients and some of those outcomes. But increasingly, we're focusing more on research and evaluation work. So, for example, our work with Mashid. So, what is the problem that we're trying to solve? So, this is from the beginning. We engaging patients who have a very extreme amount of hospital utilization. We realize that they're touching multiple systems, right? This is no surprise. More complex in terms of medical illnesses, so 5 or more chronic conditions is pretty average for the patients that we work with. Getting to know them, we learn that they're involved in all these different systems and that this fragmentation really just exacerbates all of the conditions that they present with. So we have been trying over the years to knit together this fragmented system. And part of that has been about breaking down silos and bringing, again, people to the table from competing hospitals, from different systems, healthcare, criminal justice, schools, social services, et cetera, to really work together to understand how patients touch all of these systems and how that interaction with systems either exacerbates some of the problems that our patients are facing or is beneficial to them, right? So how do we work together as systems to coordinate our responses to individuals who touch us or who interact with us in a way that we're better equipped to address the needs of individuals who come into our orbit. So as I mentioned, we very early on forged partnerships with the 3 competing hospital systems in Camden. And this initial engagement and conversations around a breakfast table led to data sharing agreements. And the data have been fundamental to us in terms of understanding population health trends in Camden and also identifying those individuals with extreme hospital utilization and really understanding them and designing our interventions around them. So these are the 3 hospital systems. We began building what's now a citywide all-payer hospital claims database. We receive the claims data from these hospitals on a regular basis. We integrate them into one system. We now, actually these are the first 3, we now have 5 systems, 2 additional systems outside of Camden. And that claims database is the foundation for this exploration of utilization of hospitals among pediatric patients. So our methodology has been healthcare hotspotting, right? It's a methodology borrowed from the criminal justice world, which Chief Commissioner William Bratton in New York City really used this methodology to great effect to reduce arrests and crime in New York. And essentially what it is saying, okay, we know as a system, a healthcare system, we spend a lot of money, right? Our expenses are rising annually. So what do we do when we see a problem? Multiple problems popping up like all over the system, throw money at it, throw resources at it. This methodology is designed to really use data to identify where the most acute need is. Where are those regions in the healthcare system that really need a high amount of resources directed at them, right? So we used the claims data, for example, to identify those individuals who are cycling across the hospital systems, all 3 hospitals, at a great frequency, and really designed our work around that small group, but very, very influential in terms of the costs to the system, right? So this is, in any system will see this. This is something I'm a sociologist by training. So when we talk about outliers in the healthcare system, it's not unique. All institutions, all systems have what we call outliers, like those individuals who just defy the norm, right? That just really shoulder a great amount, in this case, a disproportionate share of the costs to the system, et cetera. And so our systems are designed to address the needs of the middle, right? The average. Systems fall apart when somebody who doesn't quite fit the mold walks through the door. And so that's, back to that image of the problem that we're trying to solve and that fragmentation, that is very central to that, and that is what we've been working on for the past several years. So just to go over briefly, the claims data, what we've been able to learn about, the extent of how much money is coming into the system, how many patients are visiting the hospital, how many patients are going across the hospital systems. And what's remarkable for Camden is that with a population of, I think at this time it was around 76,000, 42,000, more than half is seen at the hospital on a yearly basis. And applying this sort of hotspotting methodology geographically as well as to individual level data, we found that the top diagnoses were respiratory related, bumps and bruises, pain, chest pain, pneumonia. We found that 1% of the population is suffering from more than five or more chronic conditions, and we found some averages in terms of age, averaging 4 ED visits a year, hospitalization charges, et cetera. So we use these data, again, to really understand population health in the city of Camden, and also identify that group of patients that really accounts for the greatest share of expenses and has the most complexity. So just briefly, what we've been doing over the past few years is expanding our data sharing partnerships into other domains. So again, thinking back to that picture of fragmentation, that these patients are crossing over multiple systems, and that at each, you can think about it on one hand, that each touch point with the system presents an opportunity to really address the needs in a very holistic way, address the root drivers of poor outcomes. But what happens, again, because systems are designed for the middle, not the outliers, these individuals may be touching multiple systems, and those opportunities are lost, not because folks are ill-intentioned, but because our institutions aren't equipped to deal with this level of complexity on their own. So our idea, going back to that original idea of how central engagement and partnership collaboration is to the Camden Coalition, even though we certainly have engaged different sectors, we didn't really formalize our data sharing across sectors until 2015, and we began with the Camden County Police Department. The idea was that, we can state in terms of a hypothesis. A hypothesis was that those individuals who are outliers in the healthcare system, we're gonna find a subset that are also outliers in the criminal justice system, and that if we take a look to understand these individuals more by using the claims data and whatever data we have on hand, we're going to find that there are very similar drivers, right, to that extreme utilization within both systems. So what we did is that we integrated the individual level claims data and arrest data, and this chart is an illustration of the data. So looking at the city of Camden for over 5 years, we identified 93,000 individuals visiting the hospital. These are adults 18 and over. We found overlap, a lot of overlap, around 50% of those that we found in the arrest records overlapped with the hospital. And then this tiny, tiny dot, again, going back to our methodology, was just hot spotting, right, focusing on the extreme outliers. This tiny dot represents a very small fraction of the individuals who had arrest records and hospital records, right? These are individuals who had 16 or more hospital or ED visits in 5 years and 7 or more arrests. And we use these data then to look at typologies, like who are these individuals? What sorts of groups can we identify? And how can we work with the criminal justice system to tailor interventions around them? So all that is to lead up to our study. So this, again, is a collaborative research project with Wiest, a mixed method study to reduce asthma-related pediatric hospitalizations and ED visits in Camden, and to develop interventions based on our findings from the mixed method study and engagement with patients, their families, and experts. So we first wanted to use the hospital claims data to identify clusters of children with distinct patterns of asthma-related ED visits and hospitalizations. And from there, identify individual patients and their families to have conversations with in a focus group setting to talk about their experiences and take these data and identify promising interventions to reduce avoidable pediatric asthma-related hospitalizations. So again, as I mentioned, I'm going to talk more about the quantitative pieces of this, and Wiest will talk a bit about the findings from the focus groups and the implications of this from a physician's perspective. So we took the hospital claims data from the 3 city hospitals in Camden for 2010 to 2014, 5 years of data. We identified patients 17 years or younger in the data who ever had an asthma-related ED visit. And we looked at both primary diagnosis using ICD-9 codes and secondary diagnosis for asthma. And what we wanted to do is make sure that, as far as we could control who we were looking at, we wanted to make sure that every individual that we found in the data had an equal opportunity to be observed in the data. So we found 3,170 children who fell into that age range, 17 years or younger, all 5 years. And we also assessed prevalence of sickle cell anemia, mental health, comorbidities, housing instability, homelessness, because of the importance, again, that the idea from what we found in Canada and what Wiest knows as a physician is that those individuals with extreme utilization are very complex and are going to present with all sorts of comorbidities and social complexities. And so we used, we could talk more about the clustering methodology if anyone's interested, but we used a specific methodology to generate clusters from the data. So what we found were 5 meaningful clusters of children based on their utilization profiles. So this is just a chart to, that depicts the clusters. This may not be extremely meaningful, but if we look at the x-axis of the chart, this shows the number of ED visits ranging from 0 to 50, and number of hospitalizations for asthma ranging from 0 to 11. And I want to say that these are the 2 variables that we use to cluster or to identify segments in the data. And the colors represent the different clusters that we identified, and I'm going to talk about those now. So we identified 5 meaningful clusters, and what that means is that we did some diagnostics on the analysis and observed, for example, a scree plot and that scattergram that you just saw, and found 5 groups that we could identify as meaningful. Because if you use cluster analysis is going to find clusters no matter what kind of data you use, right? So you're really careful to make sure that we're not just finding fake clusters. Wiest confirmed that these are meaningful based on her experiences as a physician. So we found the largest group were those individuals who had 1 ED visit for asthma, no inpatient utilization. Other clusters were sort of mixed between that. So for example, there was a cluster that had high ED utilization for both asthma and non-asthma complications. And then as the groups get smaller, we go to the individuals who had extreme utilization. These were folks who had, I think, around 6 on average inpatient admissions for asthma and several inpatient admissions for non-asthma related complications as well. So the point was that we were able to use these, the 2 clustering variables to identify meaningful clusters. And what we found also was that comorbidities varied across these clusters as well. As you got to the more extreme end of utilization, again, the smaller groups, the prevalence of homelessness increased, sickle cell anemia diagnoses increased, mental health increased. So we found increasing levels of complexity there, and this has profound implications for the interventions and what we might be able to do in response to these segments that we identified.
And one other thing is a term that Marie Lazon coined, which is called facility hopping, which is individuals who go to more than one facility in Camden. And we found that among the super ED utilizers, not the inpatient, the ones who get hospitalized a lot, the more you use the ED, the more likely you are to be a facility hopper. So that was kind of an interesting finding. And our paper just got accepted to the Annals of Emergency Medicine, so we're very pleased with that.
Yeah, so we, do you want to talk about some of the interventions that?
Sure, absolutely. So we actually used this data from the cluster analysis to go into the health information exchange from the Camden Coalition and actually find kids and families who fit the profiles of those clusters. And we recruited them, so we had 2 focus groups with high utilizers and 2 focus groups with the low utilizers. So the high utilizers, we had one with the kids who were 14 to 17-year-olds, and then one with the caregivers of anyone who was 13 or younger. And then the low utilizers was, again, kind of mirroring, so one group with the kids and one with the caregivers. And the idea of looking at the low utilizers was to understand, maybe look for a concept of positive deviance, because again, Camden is a very small place. And what are these families doing differently outside of the severity of illness, which clearly is a big factor? But what are they doing differently? How are they using care differently that is actually helping them stay out of the ED and the hospital? So while we're fixing the technical problem there, so these were fascinating focus groups. So the first focus group was with the high utilizer teenagers. And it was a 1.5-hour group, and the interesting thing about it is that you're talking about various interventions to use the ED less and not get hospitalized at school, at home, in the ED, in the doctor's office, in the inpatient wards. And then they kind of sort. They have decks of cards where they sort interventions that they prefer in each setting. And we were done after an hour and a half. I was saying my thank yous and goodbyes, and suddenly out of nowhere, this young lady sitting next to me says, "Doc, we really have it hard here." And this started a half-hour, almost orchestrated symphony of grievances, as if it was planned. And these children, no one was trying to one-up anyone. No one was trying to say, I have it worse. Of witnessing violence and people getting shot to death, incarceration, drug overdose, mental illness, joblessness. And as much as I always think that relative to the social determinants of health issues, the healthcare system solutions are relatively low-hanging fruit. And I wanted to keep them separate somehow. And I was like, if you hit those healthcare system kind of solutions, then it doesn't matter which population you're talking about or what kind of social determinants of health issues they have. But being in that room, and again, not that I didn't know these grievances, I know Camden, I know that they had these problems, but hearing it firsthand in that way, and it went on for half an hour, really shook me to the core. And the interesting thing was that we then went and kind of added an IRB and said, we want to ask an explicit question about life stressors, right? So in the second focus group with the parents of the super utilizers, they didn't bring up any of the stress issues. And then with the low utilizers, we formally had the question on there, like, what life stressors do you have that you think are getting in the way of controlling your asthma? And they looked at me like I had 2 heads, or I was like, why are you even asking this question? So it's as if we were onto something, that yes, in those super utilizer groups, that maybe these social determinants of health issues are really more important. Maybe they do play a role in the way that they interact with the healthcare system. So our next collaboration, hopefully with the Camden Coalition, is really understanding the way that the social determinants of health kind of affect the way that populations interact with the healthcare system and how they use it. And so that's kind of the next step, and this has been a fantastic and continues to be a fantastic collaboration. I'm so grateful for it, and thank you so much for coming, Dawn. I really appreciate it.
Thank you.